Welcome to our video on ischemic stroke. Let's begin. For ischemic stroke, we will discuss its definition, risk factors, etiology, clinical presentation, histologic changes, diagnosis, and management. Ischemic stroke is an acute neurological condition caused by a disruption of blood flow to the brain. It's worth noting that ischemic stroke is more common than hemorrhagic stroke. An important differentiating factor between a stroke and a transient ischemic attack is that symptoms of a stroke last more than 24 hours. Non-modifiable risk factors for ischemic stroke include an age of over 65. Additionally, males are more likely to develop ischemic stroke than females. Anyone with a family history of stroke or cardiovascular disease, or with a personal history of transient ischemic attack, is at risk for developing an ischemic stroke. Let's move on to the modifiable risk factors for ischemic stroke. It's very high yield to know that hypertension is the strongest risk factor for any type of stroke, including ischemic strokes. However, hyperlipidemia can also contribute to the patient's risk for ischemic stroke. Carotid artery atherosclerosis can result in an atheroembolism to the cerebral vessels, causing ischemic stroke. Atrial fibrillation can cause formation of a thrombus in the left atrium that can later embolize to the cerebral vasculature and cause a stroke. Finally, tobacco use also increases the risk for ischemic stroke. An 81-year-old man is admitted to the emergency department due to acute onset of slurred speech. He was watching TV when he suddenly felt weakness in his right hand. His past medical history is significant for uncontrolled hypertension for the last 20 years. He has been smoking 2 packs of cigarettes per day for 60 years. Physical exam reveals weakness and sensory loss in his right lower face and right upper extremity. His total cholesterol levels are 300. What is the strongest risk factor for this patient's current condition? This patient presents with acute onset of slurred speech. The physical exam reveals weakness and sensory loss on his right lower face and right upper extremity. This is a classic description of the left middle cerebral artery stroke. The patient has multiple risk factors for ischemic stroke. First, he has uncontrolled hypertension for the last 20 years. Additionally, he has been smoking 2 packs of cigarettes per day for 60 years. He has hypercholesterolemia. The question asks which one of these is the greatest risk factor for stroke. Let's recall that the strongest risk factor for any type of stroke is hypertension. Ischemic stroke is classified into several subtypes, including thrombotic stroke, embolic stroke, and stroke due to global cerebral ischemia. Let's discuss thrombotic stroke first. Thrombotic stroke, just as the name suggests, occurs due to a thrombus obstructing brain vessels. Thrombotic stroke is the most common subtype of an ischemic stroke. It happens when there is a rupture of an atherosclerotic plaque in the cerebral vessel that causes exposure of subendothelial collagen. Recall from pathology that subendothelial collagen itself is prothrombotic, and it stimulates thrombus production that occludes the vascular lumen. Risk factors for thrombotic stroke include hypertension and atherosclerosis. Remember that, in general, the greatest risk factor for any type of stroke is hypertension. Patients with thrombotic stroke typically have fluctuating symptoms with periods of improvement. Thrombotic stroke can involve both large and small vessels. A large vessel is typically occluded at the branching point of the vessel. Small vessel involvement, on the other hand, causes a lacunar infarct affecting deep brain structures. Now let's talk about embolic stroke. As the name implies, embolic stroke is caused by an embolus occluding a cerebral vessel. The most important sources of emboli include cardiac emboli, which can arise due to atrial fibrillation. As we already mentioned on one of the previous slides, atrial fibrillation can form a thrombus in the left atrium that can embolize to the brain. Rheumatic heart disease and infective endocarditis can form valvular vegetations that can break off of the valve and travel to the cerebral vasculature. Additionally, ventricular aneurysms predispose the patient to left ventricular thrombus formation that can also travel to the brain. Embolic stroke can also be caused by atheroemboli from an atherosclerotic plaque in the internal carotid artery. Finally, let's discuss paradoxical emboli, which can also lead to an embolic stroke. Paradoxical emboli are named so because these emboli arise from the deep venous thrombosis and are not supposed to reach systemic arteries. However, if a patient has either patent foramen ovale or atrial septal defect, a venous thrombus can travel from the right atrium to the left atrium through the interatrial defect and then embolize to the systemic arteries. Embolic strokes most commonly involve the middle cerebral artery. Patients with embolic stroke have an abrupt onset of symptoms with maximal symptom intensity at the onset. Finally, let's discuss global cerebral ischemia as a cause of ischemic stroke. In global cerebral ischemia, there is diffuse cerebral hypoperfusion resulting in tissue infarction. Hypoperfusion can be due to shock or bilateral carotid artery atherosclerosis, restricting the blood flow to the brain as a whole. Global cerebral ischemia usually causes a watershed infarct. Watershed zones are the most distal areas of vascular territories of the anterior, middle, and posterior cerebral arteries. A watershed infarct can happen at the border of anterior ACA and middle cerebral arteries, MCA, or at the border of MCA and posterior cerebral arteries, or PCA. Watershed infarcts can also occur at the border of deep and superficial branches of middle cerebral artery. A 52-year-old woman is evaluated in the hospital due to gradual onset of headache and sleepiness. She received low molecular weight heparin for an acute deep venous thrombosis 1 hour ago. The physical exam reveals weakness and sensory loss in the right lower extremity with hyperactive reflexes. Non-contrast head CT scan reveals hypodense parenchyma with loss of corticomedullary differentiation in the left anterior cerebral artery territory. There is no sign of intracranial hemorrhage. Which two cardiac conditions can account for this patient's current symptoms? This patient presents with gradual onset of headache and sleepiness. She received low molecular weight heparin for acute deep venous thrombosis 1 hour ago. The physical exam reveals weakness and sensory loss in the right lower extremity with hyperactive reflexes. Additionally, a non-contrast head CT scan reveals hypodense parenchyma in the left anterior cerebral artery territory. All these clues suggest an ischemic stroke of the left anterior cerebral artery. This patient had a thrombus in her peripheral veins that eventually ended up in the cerebral arteries. Normally, a venous thrombus cannot bypass the lungs because it will become stuck in the pulmonary arteries or capillaries. However, if there is an intracardiac right to left shunt, a venous thrombus can travel from the right atrium to the left atrium through the shunt and embolize to the brain. This phenomenon is known as a paradoxical embolus. Atrial septal defect and patent foramen ovale are two cardiac conditions that can account for paradoxical embolus. Ischemic stroke can manifest in multiple different ways. It can be accompanied by weakness, paralysis, aphasia, or impaired consciousness. Other signs and symptoms include headache, seizures, nausea, and vomiting. Ultimately, the clinical presentation depends on the location of the stroke. We will also review the signs and symptoms of ischemic stroke depending on the vessel involved. Middle cerebral artery stroke is characterized by weakness and sensory loss in the contralateral, lower face, and upper extremity. The reason for this is that middle cerebral artery supplies the parts of homunculus corresponding to these body areas. Additionally, patients commonly have dysphagia and dysarthria because the middle cerebral artery also supplies the cortical area controlling muscles of pharynx and vocal apparatus. Aphasia in middle cerebral artery stroke can be a result of damage to Broca's area, Wernicke's area, or both. Let's move on to the anterior cerebral artery. Anterior cerebral artery stroke is characterized by weakness and sensory loss in contralateral lower extremity. The reason for this is that anterior cerebral artery supplies the part of the homunculus corresponding to this body area. Let's talk about the watershed infarcts. Anterior and middle cerebral artery watershed stroke causes proximal upper and lower extremity weakness, sparing the distal extremities. Due to restricted motion of the proximal extremities, this syndrome is also known as man-in-the-barrel syndrome. Middle and posterior cerebral artery watershed stroke usually causes visual disturbances and visual hallucinations because this area is close to the primary visual cortex. Here we see the visual representation of the cerebral homunculus. Let's take a minute to correlate this image to the clinical presentations that we just discussed. Remember that the anterior cerebral artery supplies the medial part of the homunculus that correlates with the lower extremity. The middle cerebral artery supplies the lateral part of the homunculus that correlates with the upper extremity and arm. Let's move on to the lacunar stroke. Lacunar strokes are classified into 4 types. The pure motor stroke is caused by an infarct in posterior limb of the internal capsule. It presents with unilateral motor deficits with no sensory, visual, or higher cortical dysfunction. Pure sensory stroke, on the other hand, is due to infarct in the ventro-posterolateral thalamic nucleus. It is accompanied by unilateral sensory loss affecting the face, arm, and leg. Ataxic hemiparesis is caused by an infarct in the anterior limb of the internal capsule. It is characterized by ipsilateral hand and leg in coordination with weakness. Finally, dysarthria, clumsy hand syndrome, is due to infarct in the basis pontis. It presents with hand weakness and motor aphasia. Let's move on to the thalamic stroke. A thalamic stroke is characterized by contralateral hemiparesis and sensory loss due to damage of the ventrolateral and ventroposterolateral nuclei, respectively. Here we see the visual representation of the deep brain structures. As we discussed in previous slides, lacunar stroke commonly affects the different parts of the internal capsule. On the other hand, thalamic stroke, as the name implies, damages the thalamus. We will now discuss the medullary strokes. Medial medullary stroke is also known as Dejerine syndrome. It is characterized by contralateral spastic weakness due to damage to the corticospinal tract. Contralateral loss of vibration and proprioception is due to damage to the dorsal column medial lemniscus system. Upon protrusion of the tongue deviates ipsilateral to the lesion due to damage to the hypoglossal nerve nucleus. Lateral medullary stroke is also known as Wallenberg syndrome. It is characterized by hoarseness and dysphagia due to damage to the nucleus ambiguous of the vagus nerve. Ipsilateral Horner syndrome results from interfering with the descending hypothalamic fibers. Finally, contralateral loss of pain and temperature sensation is due to damage to the spinothalamic tract. Here we have the table summarizing the different types of stroke and their key features. Pause the video and take a moment to consider this table. Let's move on to the diagnosis of ischemic stroke. First, we need to determine the time elapsed from the onset of symptoms. This is important to decide whether the patient is eligible for thrombolytic therapy. Then we need to perform non-contrast head CT scan to rule out intracranial hemorrhage prior to thrombolytic therapy. CT scan can detect ischemic changes after approximately 6 hours from symptom onset. CT scan usually reveals a hypodense area of necrosis, loss of corticomedullary differentiation, and effacement of sulci. Here we see a non-contrast CT scan of the head showing hypodense area with loss of corticomedullary differentiation and effacement of sulci. This area corresponds to ischemic stroke. An alternative imaging modality for detection of ischemic stroke is diffusion-weighted MRI. MRI can detect ischemic changes approximately 3 minutes after symptom onset. However, it is more time-consuming and more expensive than CT scan. Diffusion-weighted MRI is indicated in case of high suspicion of stroke with normal head CT results. Here we see an MRI scan of the brain showing ischemic stroke. On the left of this image is a T1 weighted image where an area of hypointensity can be seen. On the right, there is a T2 weighted image of the same patient when an area of hyperintensity can be seen. The areas of hypointensity on T1 and hyperintensity on T2 represent an area of acute ischemia seen in stroke. CT angiography can also be performed in a patient with suspected stroke. CT angiography identifies the occluded vessel. It is indicated when there is a high index of suspicion for stroke, but CT and MRI are negative for ischemic changes. Additionally, CT angiography is indicated when patient cannot receive thrombolytic therapy but is eligible for mechanical thrombectomy. A 65-year-old man is admitted to the emergency department due to acute loss of sensation on the right side of his body. He has a past medical history of hypertension poorly controlled with lisinopril for the last 15 years. The patient has loss of pinprick sensation on his right body and left face. He has difficulty swallowing and his voice is hoarse. The physical exam reveals drooping of the left eyelid and meiosis of the left pupil. What is the best next step in the diagnosis of this patient? The patient presents with acute loss of pinprick sensation on his right body and left face. He has difficulty swallowing and his voice is hoarse. Dysphagia in this case is most likely caused by damage to the glossopharyngeal and vagal nerve nuclei, while his hoarse voice is explained by damage solely to the vagal nucleus. This patient also has drooping of the left eyelid and meiosis of the left pupil, indicating left-sided Horner syndrome. Horner syndrome in this case is likely caused by damage to descending hypothalamic fibers. Considering all these clues, this patient most likely has a left lateral medullary stroke, also known as Wallenberg syndrome. The best next step in the diagnosis of any patient with suspected stroke is non-contrast head CT scan. Other studies that could be performed in a patient with a suspected ischemic stroke include serum glucose and complete blood count. Additionally, electrocardiogram and serum troponin levels should be checked to rule out myocardial ischemia or an arrhythmia like atrial fibrillation predisposing to stroke. Urine drug screen can be performed to rule out drug intoxication. Stimulants, such as cocaine, can cause cerebral vasoconstriction, predisposing patient to ischemic stroke. Carotid ultrasound is performed to check for carotid artery atherosclerosis, a possible source of atheroembolus. Transthoracic, TTE, or transesophageal echocardiography, TEE, will reveal if there is any thrombus in the left atrium. Finally, a coagulation panel with PT-INR and PTT should be obtained to determine whether the patient has an increased risk for bleeding in case of thrombolytic therapy. A coagulation panel should be ordered immediately to guide our decision on thrombolytic therapy. Here we see the typical ECG findings of atrial fibrillation. Please take notice at oscillatory waves, absent P waves, and an irregular rhythm. Let's recall that atrial fibrillation can predispose a patient to ischemic stroke due to possible thrombus formation in the left atrial appendage. Once we confirm an ischemic stroke, we should administer antiplatelet agents, namely aspirin and clopidogrel, because they work synergistically and prevent further thrombus formation. This combination of aspirin and clopidogrel is often called dual antiplatelet therapy. We should also consider IV thrombolytic therapy with tissue plasminogen activator, TPA. Let's recall that tissue plasminogen activator converts plasminogen to plasmin. Plasmin, in turn, breaks down the fibrin and circulating coagulation factors and inhibits platelet aggregation. TPA is administered only after excluding an intracranial hemorrhage. Additionally, no more than 4.5 hours should elapse from the symptom onset in order for the patient to be eligible for thrombolytic therapy. If more than 4.5 hours have elapsed, then there is irreversible tissue damage to the area supplied by occluded artery, and thrombolytic administration will not change the overall prognosis of the patient. Complications of TPA therapy include intracranial or extracranial bleeding. Thrombolytic therapy has strict and relative exclusion criteria that should be considered before administering TPA. Strict exclusion criteria include a history of intracranial hemorrhage, tumor, or vascular malformation. If the patient has any of these conditions, the risk of bleeding with TPA therapy outweighs the benefits. Additionally, head trauma or stroke in the past 3 months or recent intracranial and spinal surgery are contraindications for thrombolytics. If the patient presents with hemorrhagic stroke or active internal bleeding, we should not administer TPA due to risk of worsening the current bleeding. If the patient's blood pressure is greater than 185/110 or platelets less than 100,000, TPA is also contraindicated. Additionally, a blood glucose of less than 50, INR greater than 1.5, PT greater than 15 seconds, and PTT greater than 40 seconds are strict exclusion criteria for thrombolytic therapy. Another treatment option is mechanical thrombectomy, which is the physical removal of a thrombus through a catheter, which is usually inserted via the femoral artery. It is used when the patient is hemodynamically unstable or has contraindications to thrombolytic therapy. For hypertensive patients, elevated blood pressure is usually tolerated in ischemic stroke patients. The reason is that hypertension maintains the mean arterial pressure, which itself is necessary for cerebral perfusion. However, if an initial blood pressure is greater than 220/120, we should reduce it to less than 185/110 before thrombolytic therapy. Let's talk about the stroke prophylaxis specifically in patients with atrial fibrillation. We use CHA2 DS2 VASC score to stratify patients into the low, intermediate, and high-risk groups. This is how we decide who needs a long-term stroke prophylaxis. Let's discuss the criteria of this scoring system first. History of congestive heart failure and hypertension each get 1 point. Age over 75 earns the patient 2 points. History of stroke, transient ischemic attack, or vascular disease like myocardial infarction each gets the patient 1 point. Age from 65 to 74 years is also assessed with 1 point. Finally, female sex earns the patient 1 point. If the total score is 0, then the patient is at low risk for stroke, and he or she does not end up getting prophylaxis. If, on the other hand, the total score is 1, then the patient is in the intermediate risk group for stroke. He or she needs an aspirin or anticoagulants like warfarin, direct thrombin, or factor Xa inhibitors. Finally, if the total score is greater than 2, then the patient is at high risk for stroke and he or she needs anticoagulants. Let's take a look at this algorithm summarizing the immediate management for stroke. If a patient presents to the ER with signs of a suspected stroke, such as aphasia or sudden onset of neurologic deficit, one should first assess their airway, breathing, and circulation and stabilize any of this if it is needed. After ensuring that the patient is stable, then they need to have a non-contrast head CT as soon as possible. If non-contrast head CT reveals an intracranial hemorrhage, then they will require CT angiography, neurosurgical consultation, blood pressure control, and supportive care. However, if the CT scan reveals signs of an ischemic stroke, it needs to be determined if the patient is a candidate for thrombolytic therapy. If the patient is not eligible for thrombolytics, then CT angiography should be performed to determine eligibility for mechanical thrombectomy. After thrombectomy, the patient will require supportive care and antiplatelet therapy if tolerated. However, if the patient is a candidate for thrombolytic therapy, then you should give them IV TPA and follow them with antiplatelet therapy and supportive care. A 66-year-old man is brought to the emergency department due to acute onset slurred speech that started 2 hours ago. He was shoveling snow in the yard when he suddenly fell to the ground. His past medical history is significant for concussion due to motor vehicle accident 2 months ago. The vital signs include a temperature of 36 degrees Celsius, blood pressure of 180/100, and heart rate of 91. His complete blood count is significant for platelet count of 120,000. Non-contrast head CT scan reveals hypodense area with loss of corticomedullary differentiation in the right middle cerebral artery territory. A resident suggests thrombolytic therapy, but the physician declines his suggestion. Which of the following makes this patient ineligible for pharmacologic management of his current condition? A. Time since the onset of symptoms. B. Past medical history. C. Blood pressure. Or D. Platelet count. This patient presents with acute onset slurred speech that started 2 hours ago. Non-contrast head CT scan reveals hypodense area with loss of corticomedullary differentiation in the right middle cerebral artery territory. These findings are consistent with an ischemic stroke of the right middle cerebral artery. A resident suggests thrombolytic therapy, but the physician declines his suggestion. The most likely reason behind this decision is that the patient has a past medical history of concussion due to motor vehicle accident within the past 3 months. Let's recall that head trauma within 3 months is a strict exclusion criteria for thrombolytic therapy. Therefore, the correct answer is option B. This is the slide reminding us of the strict exclusion criteria for thrombolytic therapy. Let's discuss why other options are incorrect. Option A is incorrect because thrombolytic therapy can be administered within the 4.5 hours after symptom onset. This patient's symptoms started 2 hours ago. Option C is incorrect because the blood pressure more than 180/110 is a strict exclusion criteria for thrombolytics. This patient has a blood pressure of 180/100. Finally, option D is incorrect because the platelet count less than 100,000 is the strict exclusion criteria for TPA. This patient, on the other hand, has a platelet count of 120,000. And that concludes our lecture on ischemic stroke and cerebral venous thrombosis.